Well, good afternoon to our offer holder day. I'd like to introduce myself as Helen McIntyre, the Associate Professor for Midwifery, and I'm going to be taking you through one of our taster lectures, which is in relation to infant feeding. And with me today I've got Colin King, who's one of our seconded lecturers, and Sarah Milnes, who is one of our lecturers. So they're acting as my audience for the purposes of today, so I hope you'll bear with us, but hope you also find this an interesting lecture to give you a bit of an insight as to the kind of things that we would do as the programme rolls on. So you'll see on this first slide that we've actually got some pictures, one of a baby in skin to skin with its hat on, which is immediately post-birth. You've got a picture in the middle that's actually in relation to brain development and the difference between the brain development with the baby who's had normal skin to skin and everyday contact with a loved person and one that hasn't, and the impact of that on their brain development. And then a quote from one of the ladies in relation to infant feeding, where although she's been successful, she'd say, well, no, it's not an easy process. But the principles are simple enough that my first reaction when I was shown was, oh really, that's it? Well, that's not bad then. So actually it's about how do we frame the whole notion of infant feeding, whether it's breastfeeding or formula feeding, to maximise it for both the mother and the baby. So I'll just take you through a few kind of examples. So one of the things that we would be asking a group of you is, what kind of benefits do you think breastfeeding might have either on the mother, the baby or society, and why do you think that might be? So any suggestions, ladies?
It reduces postnatal depression in the mother.
And it's good to help build up immunity as well.
Lovely. In the baby?
In the baby,
yeah. Okay.
Helps line the baby's gut, so the colostrum initially.
Fabulous.
Breastfeeding.
Yeah. So there's something called IgA, which is an immunoglobulin that will actually line the gut wall, which prevents infection transferring through the gut wall. So we'll talk a bit more about that later.
In terms of society, breastfed babies are less likely to get things like diabetes as they get older and obesity.
Fabulous. So in terms of a burden on the healthcare system and actually from their own mental health as well as physical health, that would make quite a big difference too. Okay.
So it's good as well in terms of bonding, thinking about those babies who we look after on delivery suite with regards to skin. It's good for attachment and just to help to regulate baby's heartbeat as well.
Fabulous, lovely. Any ideas about why formula feeding might not be so good for society? Transport?
Society. Oh yeah. In terms of, I suppose you can even go so far as greenhouse gases from cows, couldn't you?
Yeah.
With methane.
Yeah.
Plastics.
Yes.
With bottles.
Yeah.
Yeah, and just...
So it's that whole thing of actually, if it's a breast milk, then it's actually created on site, and so there's no waste, there's no transportation, there's no carbon emissions, and those things. So actually, even just from an ecological point of view, if we were going to be climate friendly, I suppose, then there are some benefits to breastfeeding versus formula feeding. So in terms of the baby, some of the early ones are in relation to actually how the jaw action moves. So if you think about holding your fingers either side of you, next to your ears, as you open and close your mouth, what you'll actually be doing is actually draining the eustachian tube, which then prevents you from actually getting glue ear and something called otitis media, which is an infection of the inner ear. We think that the clarity of speech is in relation to the way in which a baby, when they're breastfeeding, has to manipulate its mouth and its tongue, and therefore it gets used to being able to form different shapes. And very often breastfed babies also won't be using a dummy later on, which again prevents babies from babbling and just generally getting used to using their mouth and their tongue and exploring things. Increased protection against dental caries and malocclusion. The malocclusion is in relation to the way in which the roof of the mouth develops. So if you put a baby's teeth into a mouth, you'll get much more of an angulated roof of the mouth, whereas if you put a breast in, if you imagine the bulk of a breast, you end up with a much more rounded roof, and that then allows for a larger space for the jaw to develop, and therefore you get a much better spacing of the teeth when it comes through, when they come through. What we do know is that breast milk is nutritionally balanced, is easily digested and efficiently used by the babies. The other thing is there are all the other little bits that are in there in relation to nucleotides, to antibodies. So it's very much a living product, and therefore is great in terms of infection. And that's why mums and babies need to be kept together, because the mum will produce the antibodies in relation to the infections that both of them are going to be exposed to. What we know is that we will get reduced incidence of gastrointestinal and respiratory infections during the neonatal period, otitis media, as I spoke about earlier, and also juvenile onset diabetes. So that's our really young children who are going to have to be having insulin for the rest of their lives, which is quite significant really in terms of the way in which you have to live your life going forward. So this graph gives you a bit of an idea as to how important the breast milk is. So if you look at the dark navy, so that's babies who've been exclusively breastfed, and this is in relation to the incidence of diarrhoea and pneumonia or respiratory infections, and then their mortality. So the dark blue is exclusively breastfed, the turquoise is mixed feeding, and then the orange is for formula feeding only. So if we look at the incidence of diarrhoea, you'll see there's only 1 compared to 4 relative to breastfeeding and formula feeding. But then if you look at the mortality rate that goes along with that, you've almost got a tenfold difference, with only 1 dying if they're breastfeeding as opposed to 11. So really quite a marked difference, and that's even greater when we look at our respiratory infections. So we're going from 1 to 15, which is huge, and it couldn't be any more topical at the moment really. So really, really important that our babies are breastfed and that they're actually kept together with the mum to create the antibodies required. The brain development, this work was initially done by a guy called Lucas, and our preterm babies do notice a big difference in terms of their brain development and central nervous system and sight, and we've also demonstrated that now in term babies. Necrotizing enterocolitis is an infection of the gut, but particularly in preterm babies, which eventually then makes that bit of the gut die off. So if something necrotizes, it means that it's died. And obviously that then means that that baby won't be absorbing the nutrients that the baby should be taking on board. So really quite a major killer on our neonatal units is necrotizing enterocolitis. So again, when we're looking at the use of colostrum and breast milk, it's almost used as a medicine on the neonatal unit, so it's not about an optional thing. At that point it's really, really imperative to those babies. Lower blood pressure in later life, a reduced incidence of wheeze, so that's kind of like your asthma-y type things, and your eczema. Interestingly, there's a reduced incidence of obesity, and we're not entirely sure how this works, but we think it's to do with babies who are breastfeeding will only feed when they're actively hungry. Excuse me. So you can't actually overfeed a breastfed baby, whereas potentially you can overfeed a formula-fed baby. And also because you're only producing the requirements for that baby as opposed to having extras in there, then that baby's never going to be overfaced. And that sort of implantation and training from early on is really, really crucial as they go through adulthood. Reduced incidence of urinary tract infection, and again that's because of the antibodies that we've actually got within the system, and also the waste product is much more minimal compared to if you were formula feeding. Improved response rate to immunisation, so this is something that is relatively new, and what we found is that if a baby has been immunised, you actually get a response over and above what would be the normal response rate in all babies. And that extends beyond the point of breastfeeding as well. So really quite a major impact long term in terms of public health for those babies. From 2 years onwards, we found that actually there are reduced incidence of childhood cancers, so lymphomas and Hodgkin's disease. Certain allergic reactions may be reduced. We have got a lower incidence of sudden infant deaths. And also because of the one of the long-chain fatty acids in breast milk actually lines the neural tubes, we think that that's where the connections are with reducing multiple sclerosis. So in terms of the mother, we've got again a reduction in premenopausal and possibly some postmenopausal breast cancers and ovarian cancers. Hip fractures are reduced in over 65, and this is a dose-related response. So the more times a mother has breastfed, i.e. the more children she's had that she's breastfed, and the longer the time that she's breastfed her babies for, the greater will be her protection. And what happens is that the calcium is removed from the bones, but then actually you get over and above the calcium returned once that mother stops breastfeeding, which is why we kind of get that extra protection from it. The delay in the return to fertility is reliant on this mother breastfeeding exclusively and breastfeeding through the night as well, because it's important to keep those prolactin levels really high. So, and obviously if that mother starts to have periods, then that we know that those hormone levels have been dropping, so really important to keep those levels high. And we also know that women will lose weight at some point if they carry on breastfeeding. Now often that's not until they stop breastfeeding that protection and that extra fat that we've been depositing will get lost. So there are some really good benefits for the mothers as well as for the babies. Colin mentions the bonding between the mum and the baby, and that's actually a really important feature for both the mother and the baby. And those oxytocin levels that are going to be circulating will actually create really positive brain pathways within that baby's brain. So it isn't just about a gooey sense of, oh, this is lovely and I love my baby. There's actually some really hard wiring going on in the baby which will make a big difference going further down the line. Babies cry less, so if they're actually with their mums, their mothers understand them, then they will respond to their babies in a really proactive manner, and that makes a big difference. The intellectual development of babies we found is improved if those babies are breastfed, and how much of that is to do with the constituents of the breast milk and how much of it is to do with the interaction that we have with our parents or whoever it is that is looking after us, because obviously we learn by exposure and by getting involved in things. So the more involvement we can have, the more we're going to learn as we go through. Now socially, again as was mentioned before, we've got this reduced illness burden, which therefore makes a reduction in our healthcare costs. Financial savings, just in terms of buying the products, heating the water, buying the sterilising equipment, etc., etc. Being more environmentally friendly, again, we've discussed that a little bit, but if you think about from the point of where formula milk starts, which is from cow's milk generally, you've then got to process that cow's milk, so it's got to go from the farm to the factory, be processed, packaged, again transported to where it's going to be used. You then have to buy it and then you have to reconstitute it. And I think one of the key things to remember with formula milk, particularly the tinned version, is that actually that is not a sterile product. So you automatically will have bacteria in there which as soon as you start to reconstitute will start to grow, which is very different to the breast milk. So the breast milk has got antibodies that will prevent an infection, whereas the formula milk intrinsically will have some bacteria in there. So what we have to do is mitigate against that. And then this whole thing of not really understanding how we get a more intelligent workforce, but that is the case. So in the long run, we have an increase in our gross national product as we go forward. If we have mothers and babies who are feeling very grounded, who know who they belong to and how safe they feel, then actually their self-esteem will rise. And again, that then feeds into a society that is much more positive about itself and sure about itself. So this slide gives you a bit of a summary as to what you would find in formula milk and what you would find in human breast milk. Does anything strike you in relation to that slide?
The difference in the amount of ingredients.
Yeah, so really the ones that are in the formula milk are the basic things that will fulfil the nutritional needs of a baby. But actually when you start to add in all the other products, you start to see all of those extra antibacterials, the nucleotides that are actually sort of mini bits of genetic material, for want of a better word, that are going to actually develop your baby's or the baby's genetic material, and the prostaglandins, the hormones. The other thing that's really interesting in breast milk is that often there's a kind of product that is going to enable the absorption of any of the constituents of breast milk. So not only is the product in there, but you've actually got something within it that is either going to start to break it down so that the bit is more accessible, or is actually going to be a carrier across a membrane. So the baby is actually not going to have to work quite so hard to absorb those nutrients. The other thing that's really fascinating is that all of the main fats, proteins and carbohydrates are actually in a semi-digested format, so they're not at the most complex, they're halfway down the chain. So you've only got one next digestion to go before the baby can absorb it. So it's a really fast-acting kind of product, which is great. So the other thing that is quite important for the students to understand is that actually there's a very structured way in which we're actually teaching our students, and that is through using the UNICEF BFI processes. And there are some standards for you as students, but there's also some standards for the trusts. So the first stage is all about building a firm foundation. So we have to have a written policy and guideline in place, and then we plan an education programme around that and work out whether or not through auditing processes that actually what we've decided to put into place is actually doing what we want it to do. The other big thing is that we're not allowed to promote any breast milk substitutes, bottles, teats or dummies, either by the institution or the staff themselves. And this includes actually getting freebies. So going to conferences are not allowed if there are formula milk companies there. So it does make it's quite an interesting debate for people to have in terms of those subliminal messages that we actually get from formula companies. So I would urge you to have a look at some of the posters and the adverts and just see what kind of message it's telling you in relation to breast and formula feeding. So have a think about that. So as part of this programme, you will be educated to the standard required by UNICEF BFI and also the World Health Organization. And then the standards for the maternity services are that we need to teach as midwives the women to understand why breastfeeding and breast milk is really, really important to their babies compared to formula milk, and what those differences are between the two. So it's not about forcing the women to do one or the other, it's about allowing them to have enough information to make a decision. And if, however they choose to feed their babies, we have then got to support those women to have the closest relationship that they possibly can with their babies, and also develop their safe feeding practices, again, regardless as to how they choose to feed their babies. So support them in relation to the decisions they're making. So if they're breastfeeding, how do we support them over some of the the really common hurdles that women are going to get. And with a bit of support, there's no reason why they can't overcome those, and we just need to be there at the right time. And then going out, how do these women then follow that through into the next number of weeks as these babies grow? Because babies are with us for the rest of our lives, so it's really important that we get to know our babies. Okay, any questions about any of that? No? Perfect. Okay. Is it making sense?
Yes.
So one of the key things is obviously getting our mums and our babies to get to know each other, and the skin to skin that we talk about is about bare skin to skin. So literally there's a baby with maybe its nappy on but maybe not its nappy on, and the mum with their bare skin, but obviously both of them covered together. So why are we promoting skin to skin? Well, one of the biggest things is that we are going to have a baby who's much more likely to breastfeed. And on the basis of all the information we've talked about so far, I think you'd agree that that's maybe a good thing to be thinking about. The other thing that is really crucial is that the baby's temperature is going to be stabilised, and its blood sugar. And the heart rate, as we were talking about earlier, and respiratory rate will also be stabilised. Because babies cry less, then obviously they're going to not expend energy, and we want that energy that the baby takes in from the breast milk to be used for its own development. Obviously, once you've fed once, you're much more likely to realise that you're hungry further down the line, so therefore that baby is going to get into a nice pattern of feeding and settling and feeding and settling. One of the things that if we're snuggled up with somebody, then actually pain is usually reduced because you're feeling more comfortable. And if you've got a baby who breastfeeds better, then obviously the wound healing is going to be improved because of the antibodies that are within the breast milk. And also you won't be exposing that baby to other people's infections and bugs, because the mother will only produce antibodies to the infections and bugs that she's exposed to. So it's really important to keep the mums and babies together. And if we can keep down a baby's blood pressure and stress hormones, then again that will support this baby actually just developing in the way it needs to develop. I think any of you that are mums will know that if you've got a baby who's permanently crying, then actually your blood pressure starts to rise as well. So actually it's quite good to maintain a sort of stable kind of balance, really. So when we're looking at a baby that's just been born, obviously we want them to initially cry because we want them to take that first breath. But then what we find is that there's a really steady pattern of how that baby will then crawl up the mum's tummy and actually then attach onto the breast, self-attach onto the breast, and then have a breastfeed. And then after that happens, both the mum and the baby will then have a sleep and then wake up later and want another feed. So there are these 9 steps that are really quite clearly documented now that Brindy are actually developed. So all of this information in relation to skin to skin you'll find on the UNICEF BFI website. And on there are lots and lots of resources, both in terms of journal articles and also some really nice little video clips for you that you can just access and know that what they're doing is giving you some really good information. So McIntyre was the last UK-wide data collection on all of our infant feeding. And way back in 2010 we were finding that 81% of our mums did have skin-to-skin contact within the first hour of birth, which was amazing compared to the previous one when we were looking at a much lower rate. So actually, as things have gone forward, and I think probably clinically we would say that we're probably well into the 90s now, I think the thing that we're finding is that exclusivity from the point at which the babies went into skin to skin for the whole first hour until the first feed, that's actually been disrupted. So probably only about 10% of our babies will get exclusive and non-interrupted skin to skin for that first hour. So there is still some work to be done, but the babies are being given skin to skin. And again, this whole thing of actually, if we put babies into skin to skin, they're much more likely to initiate a breastfeed. So further down the line, that then means that we don't have to worry about this baby not waking for a feed, having low blood sugars, and then deciding to just sleep and not wake up. So really quite important as we go through for babies to have a first feed. Interestingly, the reasons for stopping breastfeeding haven't really changed over the years, and in the first week there's a perception by mothers that the babies are rejecting the breast, that they're uncomfortable when they're feeding and they feel they don't have enough milk. And all of those are things that as midwives with good guidance we can actually make a difference to. What's interesting, and if you go back to one of those skin to skin stages, is that actually you get babies that do quite a lot of sort of head bobbing. And as they're doing that head bobbing, what they're doing is stimulating the oxytocin, which then stimulates the nipple to become erect. So some of these sort of activities that babies do can be misconstrued if we don't actually give some sort of explanation. So quite important that we give them some guidance. And the other thing that even going further forward, sort of within the second week, this notion of actually the babies are always hungry. And that's all to do with the physiology of lactation, and somehow or other the baby has to stimulate the mother's breast to actually produce more milk. And the way the babies do that is to actually go onto the breast more frequently and for longer to actually stimulate that. And there's about a 24-hour lag between the babies being quite determined to be on the breast quite a lot and then the milk actually sort of delivering, I suppose. So that's something that mothers will see on a regular basis, and even babies who are formula feeding will have that same pattern, but obviously it doesn't impact on the mother quite so much. So it's worth reassuring mums that that's actually that is normal. Obviously not all of our women are going to breastfeed, some of them are going to formula feed. But if you think back to that slide and all the antibodies and all the antibacterials, etc., that is in breast milk, it's really, really important that our mothers actually create the formula milk and reconstitute that in the safest possible way. And what was quite startling in that last data set that we had was that only half of our women were actually doing the 3 main recommendations for making up a breast formula feed. So that was making it 1 feed at a time, making sure that the water is boiled and then cooled, and it's got to be a fresh boiled kettle, so not reboiled, and that you only add the powder to the water when you're actually going to be using it. So really quite crucial that the water temperature is at 70 degrees C, because that will then kill off a fair proportion of the bacteria, and then you have to use it within an hour. So really quite crucial messages that need to get out there. And our BAME ladies were much better at doing that than our Caucasian ladies. So again, when we're looking at our role as we go through, we've got some really clear public health messages that we need to be getting across as we go through. So in the pregnancy period, one of the things that is quite interesting is this notion of actually us getting to know our babies in utero, and actually the family getting to know our babies in utero. And that's quite important for us to then extend that understanding of a baby is in utero, is part of the family, and then when the baby comes out, then actually it's still part of that extended family. So one of the things, or some of the things that we talk about with that is actually, I'm going to skip a slide. Oops, I think we've missed some. In relation to getting to know our babies is actually giving the baby a name, singing to the baby, letting them, any siblings listen to the baby or feel the baby move. So actually introducing that baby into the family before required, before the baby's actually born. And then the notion of responsive feeding. So we talked a bit about that early on in terms of actually how mums and babies interact with each other. And the crucial bit of the more we get to know our babies, the calmer those babies are going to be. And really what this slide is saying is that babies don't just go to the breast for feeding purposes. They may well go to the breast for comfort. A breastfeed can be short or long, and babies can't be spoiled at that point. So really, really important that we don't keep trying to separate mum and baby. We need to keep them together. And those principles are going to apply whether the baby's breastfed or formula fed. If a baby is going to be formula fed, it's really important we restrict the number of feeders to 2 to 3. Again, because what we don't want to do is introduce a whole load of infections around that baby. So I hope you found that a really useful kind of background information. Obviously there's a lot more to it than what we've talked about today. What we're going to do now is just do a little bit of a kind of a skills session that we might do with you as time goes on, just to be able to give you some confidence when you get into the clinical environment. Okay, so Colin and Sarah are going, one's going to be a mum and one's going to be the midwife or the student midwife, and what we're going to do is talk you through how you might attach a baby to the breast. So who would like to be the one?
I can be the mum.
You want to be the mum? All right then. So you pin your breast to your chest if that's okay with you.
Here's where I jab myself with the needle. Okay? Good to go.
Here we go. Let's pass you your baby. So, Colin,
Yes.
how do you think we're going to need to be positioned in relation to talking Sarah through this?
Okay. Well, I need to make sure I'm comfortable myself.
Yeah.
So I would come alongside her.
Okay.
So. And then we can both see each other.
Mm-hmm.
And this is a good position as well.
Mm-hmm.
All right. And then do you want me to just talk her through?
Absolutely. So what we're teaching, one of the key things that we need to, when we're teaching our women, is to think about as teaching rather than actually doing it for them. So verbalising our instructions are really, really important. So what we're going to do is always do a hands-off technique.
Yeah.
And it's important for us to explain to the women that this doesn't mean that we don't want to help them, but actually in the long run, if they can manage it for themselves, then it's going to help them going forward. So fabulous. So how are we going to position this baby relative to the mother's breast?
So it will always depend on what sort of delivery mum's had, because if she's had a caesarean section, this position might be a little bit tricky. So it might be better off laying down on your side. But otherwise, normal birth, if everything has been okay, make sure you've had some analgesia, then we should be okay in this position. So mum might want to breastfeed traditionally this way, or what we call the rugby style underneath. So we can try different positions. And some mums think as well that they haven't got any breast milk. So what you can do is just gently, if you use your fist, do you want me to hold baby for you? Let me hold baby for you for a sec. Alright? Is that okay with you? Yeah? And just gently use your fist, yeah? And you're just doing that sort of motion around the nipple. Okay, and you're kind of encouraging the milk to flow. And what you can also do is use a C shape. And you're just kind of working down from up here, down towards the nipple where you feel going hard to the areola, that's the brown part, and just working your way around the C shape. And if you just press gently, you'll see, can you see milk coming? Yeah?
Yeah.
Okay, alright. So that's really, really, really good. Alright, so we can now have a little go and try to attach baby. Okay? So you try the position that you feel is comfortable for you.
Probably this way.
That way? Okay, no problem. So you're going to turn baby tummy to your tummy.
Mm-hmm.
Okay? Make sure you've got baby's head supported. And excellent, all right.
You need to just support the neck rather than the head. Sorry.
It's a heavy head.
Yeah, but literally you're going to have to hold it.
Okay.
Yeah.
All right.
Yeah.
And what you don't want to do is just force baby on. So baby's just going to want to instinctively just have a smell, have a feel around. So if you just gently bring baby towards the breast, and baby will just be doing what he wants to do. Can you see him just kind of licking?
Mm-hmm.
He might be just licking at the moment. And then eventually he will then start to open his mouth. Okay, he might just take just little licks, but what you're hoping is that he will just not just sit on the nipple, because that's not where the milk is. The milk is actually in the brown areola, all right? And then you're aiming for the nipple to be at the roof of baby's mouth. Okay?
Okay.
All right. So now,
So waiting for a wide gape.
that's it. So,
And how will I know that he's on properly?
well, you'll notice that, well, initially he won't be crying, okay? And you'll notice that once he starts to suck, he's then using his whole jaw. You might even see his little ear moving, okay? And the majority of the nipple is in, and you can see the part of the areola is in as well. You might not get the whole areola in, and he's taking nice, long, sustained sucks.
And how long should he breastfeed for?
For as long as needs be. You feed him on demand, okay? Usually when babies have had enough, they either fall asleep or they push it off. Some babies feed 5 minutes, 10 minutes, 20 minutes, and then you just feed accordingly as baby wants. It might be 3 hours, another 20 minutes.
Do I need to swap halfway through the feed?
You shouldn't have to, all right? So for the next feed, then you use the next breast and so on and so forth.
Okay.
But if you think your baby's still hungry, you can offer the other side, and sort of think of it as a dinner and a pudding, so that the first breast will be the one where they'll take the most amount from, and then the others sort of like a bit of a pudding really. But then start on the pudding side, the next feed, so that again the first time they go on they're obviously hungrier, so you get a bigger amount. But I suppose be reassured that there's always breast milk in there, even if your breasts feel a little bit softer. There is always breast milk in there. They're never empty as such.
Okay.
The other thing that's quite interesting is that when the babies do feed, what they'll do is actually they'll bring their jaw forward, their chin forward, and they'll actually throw their neck back. So if you imagine when you're really, really thirsty and you're taking a really big drink of something on a hot sunny day, then actually you do that, don't you? So it is really important that your baby, the whole head and neck and body are all in one line, because actually what you want is that milk to be able to just go straight down and to where it's supposed to go rather than not.
Mm-hmm.
And that means that the areola, the amount of the brown area that's exposed, you're going to have more brown area exposed above the top lip than underneath, because it's going to go on slightly asymmetrically. So it looks a bit strange, but as you've done, it's really important that baby's chin is nicely tucked into the breast, because as that baby does suckle, what it will do is massage those lower lobes, so it means that all of the milk ducts are going to be emptied or removed. So yeah.
And how do I know he's getting enough?
Well, throughout the feed, you'll notice that he'll suck and stop, and that's a normal thing that babies do. But you will kind of get to know your baby as time goes on, and if he's had enough, he'll just generally just tell you that he's had enough. Basically, he'll show the signs, he'll push it out, he'll be content, he may fall asleep. So all those are good signs.
but basically, Sarah, what goes in must come out.
Yeah.
So your nappies are going to be one of your biggest ways of knowing that your baby's doing what it is taking enough in.
Okay.
And what you'll find with a breastfed baby more than a formula-fed baby is sometimes every single feed they'll either wet the nappy or they'll soil the nappy. And you should see a change in colour in that from your baby here at the moment has just been born. They'll have a sort of green tarry stool, and as time goes on, so around about day 2 or 3, that should start to change and become a bit lighter, and then after that it'll be quite a bright yellow, and then can be a little bit on the kind of loose side, for want of a better word. So it does change as time goes on, and it is important. So if the baby's 1 day old, you would want at least what we call 2 poos. Yeah, so a 2 poo rule. So we'd expect at least 2 stools per day for a breastfed baby, or any baby really. And then you want 1 plus the day in terms of urine. So if you've got about 1 day old baby, you'd want that baby to have 2 wet nappies in that day, and 3 and 4, up to about 5 or 6 days, and then it starts to stabilise a little bit. Okay.
Mm-hmm.
So long as your baby is giving you some dirty and wet nappies, then you will be confident that there is enough coming in at the top end to come out at the other end. So lovely.
Thank you.